transition,
Sure.
you're next. Can you swap to his next?
Do I need to do anything else up here? Okay. If you need to stand or stretch. I guess I have a question for the crowd as I'm standing at the podium. What are some other places that people have come across through their work that maybe you haven't presented or you're not presenting, but that are similar to that international clubhouse, like these cool little pockets of work that are happening? Or
there's an organization called Large.
Large?
I think that it's international as well. But it's that same sort of idea, but for like physically handicapped.
Okay.
So just like a form of assisted living type environment, but you don't have to appreciate that. The idea is not
Okay. Large.
different concept, but
Similar.
It's funny, I was up in Nova Scotia while ago, and the crew up there in Halifax were working with a youth health home, and they were setting up a similar type of program, and it was just a safety house for kids with any kind of turmoil that they need to go to. Instead of trying to get them to use the nice and pocket, and those kind of houses, they may not be an international thing, but you see them.
Yeah. Yeah, it's really neat. All right, so I'd like to talk about a couple of our other programs here, and this is around. You mentioned the pediatric asthma, and we've had good success in this is one of our pilot programs. I'm going to talk to you about two of our pilot programs now, and I want to thank. I have a co-medical director, Nate Hauser, who's he's a pediatrician. So it's been a nice compliment to get him involved and help with designing some of these interventions and helping the medics and myself flesh out our work there. So the goal of this is to talk to you about two of our pediatric outreach programs. And one of them is the program with our NICU graduates about how we have designed a model to help bridge them to their transition home. And it's funny, when we submitted this abstract, we had just finished all of our work in preparation for it. So there's a little twist to the story too, where we actually haven't. Well, we'll talk about it. And then I also talk to you about how we're starting to use some of our population analytics to predict where our work might occur. So trying to promote our own referrals to patients versus waiting to be reactive and have someone go to the hospital or go to the clinic. So. And we'll go into Synagis first, but it helps treat RSV. It's not a vaccine, but it's a medication that helps boost the newborn's immune system so that they can resist better. And so the problem that we were trying to solve with Synagis is our NICU doctors were getting these kids through their first couple of weeks, the premature babies, through their first couple of weeks in the NICU, and then getting them ready to go home. And because of the way the reimbursement structure is set up, and because of the disconnect between the home care agencies and the home pharmacy agencies in our hospital, what our hospital was doing was giving the first dose of Synagis to the patients the day they left the hospital. And the challenge is that that was not reimbursed. And the medicine is, and it's important because the benefit of the medicine is it's really you have a pretty tight window of when to give the medicines, when to start the therapy, and when to continue it. And so this is just a slide that shows how the immunity kind of gains and persists over time. And so what they really wanted to do is get the medicine in as soon as they were leaving and going out into the community where they'd be exposed to the virus. And the home agencies couldn't commit to doing it within the same day of discharge. They were doing it 4 or 5 days after, and part of that had to do with getting the people registered and I mean, it was a whole kind of messy process. And so I want you to remember that there was this whole messy process that was creating a problem that they came to us to ask if we could help solve. And again, it was the cost of the medicine alone was $2,000. That's what one dose cost. So that first dose of the medication was $2,000 US. People were being held in the hospital an extra day to get all the ducks in a row and be able to give the shot. And so they came to us and said, you know, we have 10 kids an RSV season who we're doing this to. You know, our costs are ranging anywhere from, you know, $20,000 to, you know, higher. And is there a way that you can help us save that money? So we said, well, what's involved? And like, yeah, we can do that for $200. So they were like, that sounds great. So the plan was to, the plan that we have in place is for when one of these babies is getting discharged, we get notified. Our ideal state is we go to the NICU, we meet the family, and learn about their course and what. Again, another place, like, I haven't been in a NICU for 14 years, and just as a rotation as a student doctor. So that world is all foreign to me, and you know, I go in there and they're like, don't touch anything, and they're really, I think they're even more protective of their environment than like our friends at Vale Place have welcomed us there. The NICU, I mean, to me, it's even worse than an OB floor where they're like, please don't. Very protective of what they do. And what's cool is to see how they build those relationships. And, you know, the nurses really love those babies as they leave and are very protective of them, and appropriately so. So there were some skeptics on that side. Like, they're like, what are you doing? Why is a paramedic coming in here? We met with them multiple times. We picked 2 of our kind of high-performing medics who are good ambassadors for the program and said, all right, you're going to be the medics who are going to go through this initial training. Back to your point earlier where this was not covered in the Hennepin Technical program, you know, this whole NICU piece. And one of the medics was fairly reticent about doing it. She had a lot of concerns about connecting with them. So we just put them in with the NICU team, and we said, hey, these are the same kids you're resuscitating right now when they're really sick, and now you get to take care of them when they're not sick. And so that shadow experience was really helpful to kind of build that, and again, learning from the experts who are doing this with the idea that we're going to help bridge them to home. Vitamin K is a commonly given medication for these kids, so we had the medics be able to practice the injections by giving them vitamin K. And then I think really important to our program is the idea that we're the hospital's representation at home. So we really wanted that especially with the NICU team, we really wanted them to feel like we're part of your team, and we're just going to extend this love and compassion that you have for your babies back to their homes. And so right now I have to report that our outcome is we have not given any injections at home. And I'll talk, so what was really interesting, and I think as we as a profession continue to grow and work on solving these, you know, kind of going into these niches or unmet needs, Pete talks about it, we turn over a lot of stones and shine bright lights under them. And so what the system was able to figure out was that whole, you know, what was probably a good decision and an expedited decision 8-10 years ago when they first started doing these injections and paying all this money that was the right thing to do for the kids. It got them the medicine. Financially, you know, and one time, $2,000, probably a small drop in the bucket. But then as you're doing it over years, it starts to add up. But it became the way we do things. And then it was only until someone sort of asked, is it really valuable to do it this way? So they've tightened up their system. The home care companies improved their customer service to be able to give injections in a more timely fashion. We ran into some regulatory issues too, where our pharmacy couldn't dispense the medicine to us as the outpatient provider. Our plan was for the medic to go the morning, pick the medicine up from the pharmacy, go to the house and give the injection. So we ran into some regulatory issues with it that we were working out, or our pharmacy's getting a new license. But when we talk about triple aim, the fact is that we're doing better care, we're improving that experience for the patient, and we're doing it at lower cost. So we've achieved triple aim, but we just haven't seen any money from it yet. But we've gotten to meet this other team of people who are really interested and have this really cool population to work with. And so we've gone out and done a few visits where, again, a NICU kid hasn't shown up for a follow-up appointment, so the medic's gone out and checked the weight or made sure the feeding's going okay. And so we're starting to expand into our, doing some more services for home through our NICU and through our neonatologists. And then I think the other thing that we've learned is to do better intake on our programs, because we're lucky that we have a good group of paramedics who represent this whole idea extremely well. So when they're doing something at one clinic and another doctor hears about them, or a PA, or there's someone at a meeting and they hear, oh, the community paramedics are doing this, we get a lot of requests for service now. And we're starting to get better about saying, all right, well, tell us a little bit more about your problem, and what are you trying to solve with our intervention? You know, how much can you pay us? How much can we save you? Who is supposed to be doing the work right now that's not getting done? And so I think we're getting to be a little bit more wise about helping people prepare for the intervention versus someone just saying, I have a problem. It must be, you know, the community paramedics can solve it. And we do solve a lot of things, but we're getting better at figuring out when to say, or how to say yes, rather than just say yes to everything. And so that's the Synergis work, and it's connected now to our pediatric asthma program. And now this is a program that's getting more and more busy with actual patient services. So I think we talked about. I know we've talked about community needs assessment. We've talked a lot about it from learning from the community health workers or from the patients or the population. I think what we used with our pediatric asthma population, though, was some of our the state's data on pediatric asthma. And in Minnesota, there's some good tools, and a lot of these tools are connected to measures that clinics are being judged on and that are tied somewhat to reimbursement. So we have my partner, when he started his pediatric practice, he was looking at this, and their clinics being tracked on their pediatric asthma care. And so this is back to that intake process. What we're trying to get much better and better at is having people really describe their current state and what problem they're trying to solve. And so based on some analytics and just practice, we know that this is our traditional, or our current asthma care. It's, you know, you're at home, you have an asthma attack, you usually go, or often you go to the emergency department. Sometimes you go to primary care. You can go to the pharmacy if you already, you know, you haven't picked your prescription up for your albuterol, so you go and treat yourself. The school, in our area at least, feels very disconnected. And to the pediatrician's point, that's where a lot of the pediatric asthma care could occur. And when it, so we went through our analytics and identified again where are asthma attacks occurring. And our service area really is that gray kind of shaped area, but a lot of the patients right on the edge of that, and in the yellow areas where we really wanted to focus. And so what we designed was an intervention where we would pull those 108, the highest risk people. And so let's cold call them and see if they'll let us come to their house and figure out how we can help improve their asthma care. So these were patients who were known to us and kind of assigned to our clinic. So we had, phone numbers and addresses. And it was a cold call insofar as they hadn't maybe not been in, or they didn't have some critical piece of information on file, but they're at least, they knew who we were when we called, or in theory they did. And so our idea was that we'd go out and do a preventive visit with our paramedic. So we go out and assess their house. We would provide, review with them an asthma action plan, and help sort of tighten up their emergency action plan. And then that would coincide with primary care visits, where we would encourage them to go to the clinic. So we would help address the question of, well, even though you feel well, here's the advantage to going to the clinic, and here's the questions that we're going to help you be ready to answer, and then we'll try to prevent your asthma attack from occurring. And then we'll follow up with a community paramedic visit and have a graduation from that. So, and this again was a great learning, and to build on the theme from this morning, where the medics were really able to get a lot of good additional education that was focused to pediatric asthma and focused to our specific area. So when we would go in the houses, and not a lot of the mattresses, not ideal from an asthma standpoint, so there was a state grant to give allergen dust covers for mattresses, so it was a tool that we added in, and medics are bringing that out to people's houses and helping them understand why they should use that. So one of the first tweaks we had to make to the program was creating a letter that was signed by the pediatrician to landlords saying this needs to be fixed. So if we'd find mold or some other environmental problem in the house, trying to work through that and give. We didn't always send the letter, but we helped people feel like they could ask for something to be different, and sort of support that in a way that didn't feel like they were putting risking getting kicked out of their house because they were complaining. We gave them some resources to say, no, this is within your rights to do that. So, and then we'd made a lot of use of some of the other existing resources. So, and we've had a really good success now. And one of the other interesting things, when I forget, was with the spousal referral program, or when spouses were referring people, we've actually picked up some other patients or helped facilitate whole families care, because I think, again, the parents would let us in their house because they're concerned about their children. And then once that relationship was built with the medics, they would say, well, is there anything else that you're worried about? And we found some other good things through that. And so our next plan is to start doing interventions as people leave. That's our proactive component. Now we're starting to work on our reactive component, where we're picking people up as they come out of the emergency department. And this helps us catch people who are just moving into the area, who maybe haven't been established before. But same interventions, just the referral points, the emergency department. I don't know how well this shows up, but this is another really cool part. And we talk about technology and telemedicine and all this stuff, but one of the medics, her mom likes to sew, and so they made up these pediatric asthma bags. And I think this was another kind of win or a way for the medics to get in the house and make it valuable, where they're leaving this little package. It's very non-clinical. It's nice. It's soft bag. They're fun little designs. But in that, we're putting in all the equipment that they need to care for themselves if they have an emergency. So there's incentive spirometer, the mask, medications. There's their asthma action plan, the spacer. And so it's been a really good I think it's been a nice way for people to leave something at the house that's had, again, a it's been very well received by the patients. And these, the kids are really excited to have their asthma bag. And it lets them start to feel more, or it adds to their feeling of being in control of their health. And then our plan phase 3 is to start to get this involved more and more in the school. So again, another little bit of a closed environment, but there's been some discussions about could we drop a medic in and supplement some of the school nursing, or so we'll see how that goes. But and then I think our final, this is our holy grail, is people will be able to do the in-home asthma treatment, so treat the exacerbation in the home and not go to the emergency department, bridge people through, and then be able to get them into the clinic. So that's we're baby steps, but that's what we're working towards. And that that's going to include then. I'll bring it up today to start it off, but I think this opens up some of that mobile integrated health idea where you have a paramedic who's not a community paramedic or an EMT who's able to respond and initiate this therapy, while the community paramedic then is coming within an hour or 2 hours. So questions on either the synergists or the pediatric asthma?
You have some really great programs that you've described. Now, I was wondering, some of the questions before, what is the distribution, or what kind of percentage of the funding comes from reimbursements versus, you mentioned at least one grant in there to fund these innovative programs?
Yeah, so, our program, 4 years old. Initial funding, we were very successful with some cost savings that have been able to get our program to keep moving along. I think one of the challenge, and I think that's one of my main concerns as we build programs built on cost savings, is the memory of that cost savings starts to disappear. So what was savings 2 years ago starts to become cost now. So that's a challenge we're dealing with daily. I think we made that comment earlier, where we're starting to tighten, or we're starting to say no to certain things, and unfortunately becoming more payer aware versus payer blind. So and in the state of Minnesota, we're fortunate with Medicaid, where that's a reimbursed service, and a lot of our asthma patients qualify for some kind of reimbursement there. There's some still, so that's one component. There's still groups or areas that are being paid for value-based work, and we're very effective in that world because of our cost structure. So for the groups that are interested in value, it's not an easy conversation, but it's a conversation where we stand up well. So we have a program going with our bariatric surgeons who get a bundled payment for the work that they're doing with their bariatric surgery, and then we help keep people out of the hospital for them and provide higher customer service. So there's a lot of room, I think, for the value-based discussions. Grants are still I think that we're still in a time where grants are, that's a ripe vein for things. And then we're starting to connect more with payers. So that's been the other interesting conversation, that we're in the middle of a pilot with Blue Cross in Minnesota, where they're paying us to see their patients. So these people are leaving different hospitals. They're not connected to our hospital, but they have a Blue Cross product. And the Blue Cross product then is what's driving the referral to us. It's been another really fun rock that we're turning over, because Blue Cross is like, oh yeah, here, call them. This is their number. And people have been, they're not discharged, they're deceased. So we're sorry we called that family and asked about coming to see their dead parent. But it's another one of those. But it's been really good, because when we first started meeting with Blue Crosses, they're like, oh no, we got really good numbers. These are good. And no, they're not that good, but they've been helpful. They've been keen on their feedback, and they're fixing it. But So that's working with the payers, continuing the value conversations. There's still the memory for us of the value and the grants. We have not gotten into like charging patients, but that might be, I think there's a value conversation to have with patients to say, hey, we can do this, but this is the cost. But what else would you add, Pete?
So our goal together, and the reason we ended up kind of taking our roles, was to increase the percentage that we're paid within Medicaid, and we're doing that. So we've got some good goals for the next year and plans to reach them. So, and then I think watching what's going to happen here in the next couple of months could lead to some block grant opportunity or per capita care cost similar to value-based. So we're excited, right? Right?
But I think too that on that value-based discussion is the idea of contracting with different groups who have a need and right now maybe are using someone else. That I think I'd be surprised if anyone disagreed. But the medics who are good at community paramedicine right now, because there's not hundreds and hundreds of them, they're really good people persons. So they provide good service. And I think it's a nice way to leverage. You get this really, kind, smart person to come in and interact. So there's that value discussion becomes easy. And I think there's some ability to go into someone who's right now maybe has a nurse that comes, or another medic that comes in, or a PA, somebody who maybe they're just kind of doing a job. They're not really providing a service. So there's some ways to sort of offset the cost so we can still see the people that, I think this is another part of our program. We still want to serve the people who don't have insurance, who are kind of marginalized. And I think that's where the passion came.
I'm going to add one other thing. If it's possible within the organization that you're working in, we developed a tool early on in a product called ClickView, and every patient that we see automatically dumps into kind of a data lake that's monitoring their pre-post spend. And that's just pre-post what we're billing out. And we're hard-pressed to find any population by payer, by age. No matter what we do, it's about a 48% reduction in utilization. And that's at a 6-month look. So we're looking at 4 weeks, 8 weeks, 12 weeks. And so I think that it's pre-post methodology, so it's not as concrete as some, but it's great. It's a good way of seeing how are patients utilizing the system. And we've seen a major shift from ED or acute care to primary care. So,
and I think, you mentioned that the question of are we increasing costs potentially? And I think we've seen that with our initial intervention, especially as it crosses over to past utilization. And as reporting lags a little bit, the cost does go up, but then it comes down quite, in a good way after that. So, but it's fascinating, the whole economic part of it all. Other questions or comments? Good, thanks.
Okay, we're on break until 10:30.